Today, I'm going to talk about geospatial risk models for tropical disease mapping. First, a little bit about my research. In September, I will join KAUST as an assistant professor of statistics, and I will be the principal investigator of the Geospatial Statistics and Health Surveillance Research Group. My work focuses on the development of statistical methods and computational tools for disease surveillance. I have developed methods to understand the spatial variations in temporal trends of diseases, and here we apply it to monitor cervical cancer in white women in the United States. I've also developed methods to integrate data at different spatial resolutions, and here we apply it to combine point level and area level data of air pollution to construct a spatially continuous surface that can be useful for policymaking at the local level. And I've also developed point process models to understand how hepatitis C virus propagates in human livers. I also developed software, so my methods can be widely available and provide benefits via my own applications. I'm the author of a Spatial Epi app, and this is a shiny web application for disease mapping and the detection of clusters. And I'm also co-author of the packages EpiFlows for risk assessment of travel-related spread of disease, and dCluster-M for model-based detection of disease clusters. I also collaborate with multidisciplinary teams looking at how diseases distribute in space and time and identifying risk factors. I developed a modeling architecture to predict lymphatic filariasis in sub-Saharan Africa. This is a disease also called elephantiasis. And I participated in a project identifying risk factors of leptospirosis in Brazil. This is a disease transmitted by the urine of the rats and very common in urban slum communities. And another project assessing the effect of two interventions, larval source management and house improvement, on malaria transmission in Malawi. As I said before, I'm joining KAUST, and I'm looking for outstanding PhD students and postdocs to join my group. So if you are interested, please get in touch. So this is the outline for today's talk. First, I will introduce geospatial data and methods for surveillance. And then I will talk about two different applications. One of them is lymphatic filariasis modeling in sub-Saharan Africa, and the other is leptospirosis modeling in Brazil. So as many of you know, this is John Snow map of cholera in London in 1854. In that year, there was an outbreak of cholera in London, and people didn't know how it occurred because they didn't know how cholera was transmitted. So Dr. John Snow mapped the deaths, and he found out that all deaths were clustered around a water pump in Broad Street. So he convinced the authorities to remove the water pump, and when they did that, the outbreak disappeared. This is one of the first examples of the importance of geospatial methods for disease surveillance. These methods use data on disease cases, individuals at risk, and risk factors, and they are useful to understand geographic and temporal patterns, measure inequalities, identify potential risk factors, early detection of outbreaks. The results of this analysis can be communicated using maps and other visualizations, and they are very helpful for decision makers to better allocate limited resources and to design strategies for disease prevention and control. Many of these methods are also useful in other disciplines, as we have seen, that use georeference data, such as ecology, demography, or criminology. Spatial data can be categorized in 3 types: aerial data, geostatistical data, and point patterns. In aerial data, the region of a study is partitioned in several sub-areas, and we know the number of cases, the population at risk, and risk factors in each of the areas. And the objective is to estimate what is the disease risk in each of the areas. In the statistical data, we assume that the risk is a spatially continuous process that we can measure at specific locations. Here, for example, we have prevalence surveys of lymphatic filariasis, where we have conducted surveys at these specific locations, and we have measured prevalence. And the objective is to predict what is disease risk in areas that are not sampled. And in point patterns, the data are the locations of the people with the disease. So here, for example, we have, this is the city of Valencia in Spain, and the points represent the locations of people that have kidney disease. This is the same as here, where the dots represent the locations of people that died from cholera. And the objective in point patterns is to understand what is the process that originates this data. Are these data clustered? Are they at random? Are they close to a contamination source? So if we work with aerial data, we can estimate disease risk using the standardized mortality ratio. This is the number of cases observed in an area divided the number of cases expected. So if SMR is equal to 1, the number of cases observed is equal to the number of cases expected. If SMR is greater than 1, we have more cases observed than expected, so we have high risk. And if SMR is less than 1, we have less cases observed than expected, so we have low risk. SMR are very easy to calculate, but they may be misleading and unreliable in areas with small populations or rare diseases. So imagine, for example, that we have an area with very low population and we have 0 cases. So we will get that the SMR and the risk is 0, which is not true. Or imagine that we have 1 or 2 cases and a very low expected value. In that case, we would get a very extreme value that is also very misleading. So instead of calculating SMRs, what we do is to use models that enable to incorporate covariates and to borrow information from neighboring areas to obtain a smooth relative risk. So we can use this model, for example, conditional on the relative risk of area I. The number of people with the disease in area I follows a Poisson distribution with mean the expected count times the relative risk. And then we can say that the logarithm of the relative risk is equal to some covariates plus random effects. So here, the fixed effects quantify the effects of the covariates on the disease risk, and the random effects represent residual variation that cannot be explained by the available covariates. For example, we can put a spatial random effect to acknowledge that areas that are close to each other may have similar risk. And also we can have an independent random effect and a structured random effect to recognize that areas may have risk independent from the other neighboring areas. In the statistical data, we assume that we have disease risk is a spatially continuous surface that we measure at specific locations. And we want to predict the risk in areas that are not sampled. So we want to go from this map to this map that shows a spatially continuous surface of the disease risk that can be useful for decision making. And we can use a model like this. So here at each of the locations, xi, we conduct a survey. The survey has ni people, and out of that ni people, yi are positive. So the model is the following. Conditional on the true prevalence at location xi, the number of people that tested positive for the disease follows a binomial distribution with parameters ni, that is the number of people in the survey, and the prevalence. And then again, we can say that the log of the prevalence is equal to some covariates plus random effects. And the covariates, the fixed effects quantify the effects of the covariates on the disease risk, and the random effects model variability that cannot be explained by the covariates. And in point patterns, we assume that the point pattern has been generated as a realization of a point process, and we are interested in identifying patterns in the distribution of the observed locations, estimate the intensity of events, or learning about the correlation between the locations and spatial covariates. So if you're interested in learning more about spatial data and methods, you can take a look at this book, Geospatial Health Data, Modeling and Visualization with R, INLA, and Shiny. The book is freely available here in this link, or you can also buy the physical copy. And the book describes how to manipulate and transform aerial spatial data and how to create maps using R. It also shows how to fit and interpret Bayesian models using the INLA and SPVE approaches. And it shows how to create interactive visualizations, reproducible reports with R Markdown, dashboards with Flex Dashboard, and Shiny web applications that facilitate the communication with collaborators and decision makers. Okay, so this is the first example of modeling. So this is modeling of lymphatic filariasis in sub-Saharan Africa. And this is work done in collaboration with researchers at the London School of Hygiene and Tropical Medicine and other researchers in the UK. Lymphatic filariasis is a disease, it's a neglected tropical disease caused by microscopic worms and transmitted by mosquitoes. So when the mosquito bites the person, the worms go to the lymphatic system, and there they cause blockages that cause swelling of the arms, the legs, and also thick and hard skin. This is a very painful disease. People with this disease are rejected by those in their communities, and this leads to a lot of suffering and to poverty as well. Lymphatic filariasis occurs in tropical and subtropical regions of the world, such as sub-Saharan Africa, Asia, the Pacific, and also parts of the Caribbean and South America. The main strategy against lymphatic filariasis is mass drug administration, which is recommended to populations in regions where prevalence exceeds 1% annually for at least 5 years. Ideally, we would give the drugs to everybody that needs them, but in reality, resources are limited, and we need to decide which are the areas most in need. In this study, we want to predict lymphatic filariasis prevalence in sub-Saharan Africa This is the data we have. We have 3,197 surveys that were conducted between 1990 and 2014. So here we can see that in Ethiopia and in the center of sub-Saharan Africa, we have surveys with very low prevalence. And then we can also see that there are regions, for example, here in the West, with surveys with higher prevalence. These surveys give us an idea of the burden of the disease, but we don't know anything about these areas where we don't have surveys. So what we want to do is to use this information to go from this map to this map that shows a spatially continuous surface of the prevalence to inform decision making. And this is the model we use. So this is as I said before, this is what we do. So conditional on the true prevalence at location xi, the number of people that tested positive for lymphatic filariasis out of NI people in the survey follows a binomial distribution with parameters NI and the prevalence. And then the logit of the prevalence is expressed as a sum of covariates and random effects. This is a vector-borne disease, so we can use covariates based on characteristics known to affect lymphatic filariasis transmission, such as precipitation, vegetation, elevation, land cover, population density. And then in the random effects, we use a zero mean Gaussian process with a Matern covariance function to model residual spatial variation. And then another random effect that is zero mean Gaussian distributed to model variability that is common for all the individuals in the survey. And these are the results. So this is the mean prevalence. We see that prevalence is lower in Ethiopia, in the center of sub-Saharan Africa. We have higher prevalence in the east coast of Africa, east coast of Madagascar, and also in pockets in the west. And we also computed lower and upper limits of 95% credible intervals to give us a measure of the uncertainty of these predictions. So these maps are very useful because they allow to identify areas that require enhanced interventions. And they're also useful for setting a benchmark for evaluating the impact of future interventions. And in the second study, I'm going to talk about modeling of leptospirosis in Brazil. And this is work done in collaboration with researchers at Yale University and Lancaster University. Leptospirosis is a disease transmitted by the urine of the rats or an environment contaminated by the urine of the rats. People with this disease may have fever, headache, and other more severe symptoms such as pulmonary hemorrhage syndrome. And this disease is an urban health problem due to the rapid and disorganized expansion of urban centers that creates ecological conditions for rat-borne transmission. And it affects vulnerable populations such as farmers and residents of urban slums in the tropics. We're going to study leptospirosis in Paula, Lima. Paula, Lima is an urban slum community in Salvador de Bahia in Brazil that hosts a densely populated community with a high annual incidence of leptospirosis. Here we have an aerial photograph. We can see that we have 4 valleys. In the bottom part of the valley, we have a lot of vegetation and we have the worst sanitation conditions. And the upper part of the valley are close to a main road And here the sanitation conditions and the infrastructure are much better. Here we can see some photographs. We can see that households are placed at different elevations. The community has a lot of vegetation, accumulated trash, open sewers, and people carry out risk activities such as being in contact with mud and water that can be contaminated. So here the objective is to understand the spatiotemporal patterns of leptospirosis and identify targets for intervention in Paula, Lima. We recruited 2003 subjects and followed them for a 4-year period. And each year we administer questionnaires and GIS mapping to determine socio-behavioral and environmental risk factors. We fitted a spatiotemporal mixed model. So here, Yij is equal to 1 if individual I at time j has the disease and 0 otherwise. And we say that conditional on the true prevalence at location Si of the individual I and time j, Yij follows a binary distribution with probability the prevalence at location Si and time j. And then the logit of the prevalence is equal to some covariates plus random effects. I will talk later about the covariates we are going to use, but regarding the spatial effects, the random effects, we have a spatiotemporal random effect. This is an autoregressive model where the value at time j is dependent on the previous time, j minus 1, and also a zero mean Gaussian process that is independent in time, but spatially dependent at each time j. And then we also put another random effect to model variability of individuals across time. And these are the covariates we recorded. They are grouped in eight categories. We have demographic and social status factors such as gender, age, being illiterate. We have health factors such as diagnosed with dengue since last visit or vaccinated against yellow fever. Occupational exposure such as working in Paula, Lima or working in garbage removal. Household environment variables such as elevation of the household or distance to the nearest waste sewer, trash dump, household floods. We also have household and work behavior such as contact with flood water, sewer water, mud or trash near house or near job. We also have household and work reservoirs such as observing rats near house or near job and number of rats observed at a single time. So we have all of these variables. Now we're going to follow a procedure to select some of these variables to be in the model. And this is what we do. So we have 8 groups, and within each group, we fit a generalized additive model using all the categorical variables, nonlinear effects of the continuous variables, and interactions between them. And then we remove covariates one by one until we obtain a model with minimum ALC. So in the group demographic and social status factors, we select some covariates. In the health factors group, we select other covariates. In the occupational exposures, we select other covariates, and so on. Then we put all the variables together, and again, follow the same approach. We fit a model, a generalized additive model, using all the categorical variables, nonlinear effects of the continuous variables, and interactions between them. and explore further simplification by backward elimination until it's not longer possible to reduce the AIC. So finally, these are the variables we select to be in the fixed effects of our model. We have year follow-up that can be first, second, third, or fourth year. Gender, that can be male or female. Being literate, that can be literate or illiterate. House elevation, observing rats near house. This can be observing or not observing. Contact with mud near house. This is contact or not contact. And a nonlinear effect of age. And here we're going to introduce the nonlinear effect of age as a piecewise linear function with break at 20 years. And these are the results. We see that the risk of leptospirosis is higher in year 4 compared to year 1, and is lower in year 3 compared to year 1. We also see that risk factors are being male, being illiterate, observing rats near home, and contact with mud near home. And then we see that the risk of leptospirosis increases with age until age 20, and then is more or less constant. And this makes sense because young people have more risk activities, such as being in contact with mud and water that can be contaminated. These maps show the areas with the highest in red and lowest in blue odds of infection over time. So we see that we see that the areas with the highest and lowest odds of infection are more or less the same over time. The areas with the highest risk are located in the lowest part of the valleys where the conditions are worse. And the areas with the lowest odds of infection are located in the more elevated areas. So the model included fixed effects and random effects. And now we can examine the residuals to see, to identify areas where the risk is higher or lower than predicted by the risk factors. For example, this is an area where the residual is 0, and it's a high-risk region in which the measured risk is consistent with prediction. And we have a lot of vegetation, accumulated trash, open sewers, and rats can be seen very easily. This is a location of high positive residual. So the risk is higher than predicted by the risk factors. And this is because there is poor household construction and there is flood risk due to poor infrastructure. And these are locations of high negative residual. So the risk is lower than predicted by the risk factors. And this is because there are open sewers, which increase the risk of leptospirosis, but these open sewers have structural barriers to stop overflow, which decreases the risk. So to conclude, we have seen that young adults, males, and individuals with low social status may have activities that place them in more frequent or more intense contact with source of transmission. We have also seen that adequate sanitation systems may reduce the burden of leptospirosis by protecting residents from contact with contaminated soil and mud during heavy rain events. And we have also examined the residuals, and by doing that, we have been able to identify areas in which transmission risk cannot be adequately explained using non-risk factors, and this allows the identification of new hypotheses about transmission. So these are some references, the Geospatial Health Data Book. These are some papers about statistical methods and packages for, and R packages for disease surveillance. This is the paper about spatio-temporal determinants of urban leptospirosis transmission. And this is the paper about modeling lymphatic filariasis in sub-Saharan Africa. And that's it. Thank you very much.
Thank you so much, Dr. Paula, for your wonderful presentation. It's really striking to see all the pictures from the developing countries, to see the health conditions the people are facing. And also it's fascinating to see like how the spatial model could be useful to shed some useful insights for developing strategies for stopping the diseases. So we got one question from the audience from YM. Could you please unmute yourself to ask the question? YM, or is this a short name? Okay, so if you don't mind, I'm just going to ask on your behalf. The cell 31 has a graph. Can you please tell what does the y-axis mean and why it comes with negative values? The cell 31, you mean like the page 31, right? Has a graph. The page 31 has a graph. Can you please tell what does the y-axis mean and why it comes with the negative values? So Dr. Paula, if you can share your slides again, that will be helpful.
So is this graph, no? This is slide 31?
Yeah. Yes, slide 31. Yeah, that's correct.
Yes, so here, well, this is a graph that I obtained when I fitted the generalized additive model. So what I try to do is instead of using a linear effect for the continuous covariates, I want to understand if maybe the effect of the covariates is not linear. So, and what I do is to fit a spline. So there is an R package that is called NGCV by Simon Wood. And this is the result. So here, the independent variable is age, and then the dependent variable is the leptospirosis risk. And this package fits a flexible function that allows to identify if there is like a different, if the effect of age on the response is not linear. And here we can see that the risk of leptospirosis increases with age until age 20, and then decreases a little bit, and these dotted lines are confidence intervals. So here we get negative values just because the way that the package works, it centers at 0, and the sum of the values is 0. That's why. And this allows us to understand what is the shape, and then we can include this as a piecewise linear function in our model.
Okay, great, thank you.